So we are officially recording, and I'm going to minimize so I can see the screen, and hopefully y'all can too. All right, so welcome to our December Becoming Baby Friendly in Oklahoma webinar. This is Becky Mantle. I think I know everybody that's on the webinar so far today. How's everybody doing? Did you have a good Thanksgiving? And I see somebody else has arrived too. Anyway, I will, let's see if I can move my slides forward. There we go. So we're going to be talking about kind of continuing our series on the evidence behind the 10 steps. So today we're looking at steps 5 and 6. So more on that here in a minute. Always have a disclosure slide, no financial interest or anything, no conflicts of interest here, though I will brag that that's a picture of my grandson, who is soon to be 5 months old, actually, later this week, doing very well. So I guess my disclosure is being a proud grandma for the first time. Very exciting. Anyway, and here is our Breastfeeding Resource Center team. That's me there, of course, on the left, and then Petra Kalindris. Sarah is our main office administrator guru, and Amanda Parsons is the newest member of our team, who is part-time helping cover some of our outpatient lactation services. So just a few quick announcements. The November webinar, we tried something different because there was a free webinar hosted by NICHQ, which seemed like a really good fit for the topics that we try to cover in these webinars, and it was about discussing breastfeeding and the kind of the counseling piece with moms in the hospital setting. So if you weren't around or available to watch that, we do have that posted on the OBRC website, so you can view a recording or you can download the slides. I know it's always, for me, sometimes kind of quick and easy to skim through the slides if I missed something that I thought would be of interest. And this one had some good stuff in the slides. And then there's also a portion where they actually had some conversations and some role play. So you won't get that piece just by reviewing the slides. But those are available as time permits or the need arises. And we've been trying to kind of keep track each month of what are any kind of health awareness events or days or weeks being celebrated that month. And so for December, really what wasn't a whole lot that relates to us, but the 1st of December was World AIDS Day, and last week was National Hand Washing Awareness Week. I didn't know there was such a thing, but maybe y'all celebrate that and focus on that in the hospitals these days. I don't know, but anyway, that's where we are on that. I also wanted to share a couple of things from COBA, our State Breastfeeding Coalition, that COBA is going to celebrate the grand opening of our Oklahoma City Baby Cafe, and that's going to be on Saturday, February 2nd at the Cole Community Events Center in Oklahoma City. And we'll have more details to follow. It'll be kind of a come and go sort of thing, and I'm not sure of the exact time, if it'll be like a 12 to 2, 11 to 1 sort of thing. But that Baby Cafe reopened actually the end of September, so we're excited to finally kind of have the official grand opening as Baby Cafe USA encourages us to do. So, and otherwise, if you have any other kinds of events to share, definitely I'm going to see, and I know Ruth's on the phone today too, so we have a new events calendar on the COBA website. And I'm going to see if I can get it to open up and show up on my screen for y'all so we can. So if you go to the main COBA website and then just scroll down, and then here's the calendar where you can click, to future months and stuff. So definitely looks like we need to get some things on there. I know, Ruth, we can put that Strong and Healthy Family Expo on January 18th that COBA is going to be exhibiting at. So now, let me see if I can get out of here. I'll just do that for now. Okay. And if you have any breastfeeding related event that you'd like to promote through COBA's calendar, definitely contact us by email there, as you can see. So, all right, so let's focus on our topic today, the evidence behind steps 5 and 6. For shorthand versions of step 5 is show mothers how to breastfeed. Step 6 is that exclusive breastfeeding piece. So here are the references that just get those out of the way up front. So you know you have those to refer to if there's a question about something, or you want to look at something in more detail from one of the slides or citations. So that's available for you. All right, so let's look at Baby Friendly USA. Just a couple of slides here to kind of remind us when they updated the guidelines and evaluation criteria, and those came out in 2016. They kind of added this new little section up front of kind of some overarching key tenets, really key reminders for us to keep in mind as we look at the whole, baby friendly program. So, some of their key points, of course, are, breastfeeding is scientifically recognized as the optimal method of infant feeding. So we should be promoting breastfeeding. And then the second bullet here is really all about the health care facility should be striving to provide best practice, optimal care based on the evidence that we know at the time. So what's been documented in the scientific literature that supports, the best or most effective approaches to supporting breastfeeding in the birthing environment. So those are a couple. And then I think these are really important as well. So, and this probably also relates to some of the misperceptions about baby friendly out there, that it's baby friendly and mother unfriendly, if you will. So they're just, also stressing that the birthing environment shouldn't be punitive. It's not meant to be, restrictive, but the goal is to facilitate informed health decisions by the mother and her family. So I think that's a really important one for us to remember. The healthcare environment should be sensitive to cultural and social diversity. And then this last one, that the family should be protected in our environment when they are in our healthcare setting, whether it's a clinic or hospital. But of course, in this case, we're particularly talking about the birthing environment. But we want to protect them from that, commercial promotion. So that false or misleading product promotion and the marketing piece that can tend to undermine those informed decisions that we want to help families make. So, so any questions from anybody on that? And I should be able to see if anybody types in the chat box too. Now we've had a few more people join us since we got started. Okay, so those, and that's not all of their key tenets, but those are some, I think, key ones to remind us of today. All right, so let's look at the World Health Organization's publication or their review of the evidence. And for those of you that may not have been on some of the earlier webinars where we went through steps 1 and 2 and then steps 3 and 4, just a reminder too that frustratingly enough, when the WHO published these, they published a second document, and they came out within a few weeks of each other, and they have almost exactly the same name. So they published a review of the evidence, which is what we're looking at, and then they also published kind of an update to the guidelines. So and any tweaks or changes they made. We actually had Trish McEnroe do a webinar for us earlier this year to kind of, give Baby Friendly USA's take on those revisions. And of course, it's a slow moving train. They're not going to make major changes without really studying those and also giving hospitals enough notice of any changes that they might make to the guidelines. So we just stay the course for right now until they, tell us differently. Anyway, so the WHO review of the evidence, their target audience, of course, is, big picture people, policymakers, advisors, technical staff, any kind of, national or regional or multinational organizations that may be implementing some kind of program related to infant and young child feeding. They also can be very helpful for healthcare professionals such as us and people, programs such as our BBFOK program to help us disseminate accurate information as well. So there we have that. So let's look at step 5. So when we go to the Baby Friendly USA guidelines and evaluation criteria, step 5, just copied straight out of the guidelines, says show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants. Now, if they ask Becky Mel to help them tweak some of the wording, I can always do a little bit of wordsmithing because I would want to say how to maintain lactation, especially if they are separated from their infants. So, because we definitely want to address that. So, but I'm not in charge. Okay, so in the details, as those of you who are working hard are already baby-friendly designated, there are quite a few details to each of these steps. So when we get down into the weeds, some of the other bullet points under step 5, 5.1 is help the mother with position and attachment, position and latch within 3 hours after birth. Now, this isn't the first time, of course, that we help her with that, because if we've implemented step 4, we've already had skin to skin and early initiation or breastfeeding, baby attaching within the first hour, and we've offered help during that time period. So this is kind of phase 2 of that. We should have already initiated, and we should now be coming back with additional offers of help in a timely fashion. So I think in many hospitals, unless you have LDRPs, this is going to be maybe after the mother and baby typically have recovered in labor and delivery and then been moved to a mother-baby unit. So this would be the next opportunity for maybe that handover of staff and the next staff person to offer help. But anyway, and we should be just kind of helping her with basic breastfeeding practices and what does she need to know before she goes home, with her baby. 5.2, of course, it gets into that separation piece, and we should be starting some form of milk expression within 6 hours, giving express breast milk to the baby and using express breast milk before we use any other kind of supplementation, and particularly any kind of breast milk substitutes. So EBM, if we have it. And then 5.3, of course, is the formula piece. So mothers who are feeding formula should also be given written and verbal instructions so that they are also optimally, safely feeding their babies with the formula that they'll be using when they go home. So that's pretty much directly out of the Baby Friendly USA guidelines. When we look at the WHO, and once again, it's, they titled it guideline, but it's their review of the evidence. So I always have that in parentheses to make sure we're clear what we're talking about here. So they have step 5 in this. They broke the 10 steps down into kind of like, I'm thinking 3 main kind of groupings. And so one was immediate support to initiate and establish breastfeeding. And so that's in the same little grouping as step 4, as you can imagine. And so their question, as they, looked at the available evidence, was should mothers giving birth be assisted with correct positioning and attachment so that their infants achieve proper, effective suckling compared to not assisting mothers to position and attach? So should we help with position and latch, help the baby achieve effective suckling versus not doing that And will that increase rates of exclusive breastfeeding during the stay at the facility? And so what they said in their publication was, when they looked at the evidence, the overall quality of the evidence, this was still a very much recommended practice, and it was moderate quality evidence. So when we look at kind of the main evidence that they cited, often if they had a really large, systematic review, like a Cochrane review or something, that would be the main study that they would cite. And remember, too, that one of the challenges, or I think one of the comments we heard from Baby Friendly USA and a number of other organizations about WHO's review, was that they really focused mainly on randomized controlled trials. They didn't really allow any quality observational studies in their review of the evidence, when a good observational study in this field of breastfeeding and lactation can also give us some good evidence. So with that caveat, so they actually had a fairly recent Cochrane review from 2017, and this was a review that looked at over about 100 studies with 83,000 mother-baby pairs, so really good numbers. And they looked at standard care versus any kind of breastfeeding support, and they categorized that as practical, kind of that hands-on, emotional, educational, or social breastfeeding support. And their overall conclusion from this review was that when we gave any kind of breastfeeding support, it did increase duration and exclusivity of breastfeeding. So as we kind of look at this in a little more detail, they went into what that support, some of the characteristics of what seemed to be the most effective support, what that included. And the first one, I thought this was really good, that it's offered as standard by trained personnel during antenatal or postnatal care. So to kind of reword that a bit, that we should have personnel who have adequate training to provide that support, and that it should be standard of care. This should just be routinely happening, not on special request. So the second point here is that it includes ongoing scheduled visits so that the women or the parents can predict when that support will be available. So what that, obviously, if it's prenatal or postpartum, that's going to be, clinic visits or some kind of scheduled home visits or something. Do we have home visiting staff and that support and that sort? In the hospital, that's going to entail, or is she going to get support, through step 4 with, someone that's going to help her in the first hour? Is she going to get further support when she gets transferred to her mother-baby room, or, within a few hours? Is she going to have can she expect support, trained support on the night shift? Can she expect support the next morning? Not, does she get support in the first hour and then, good luck when you get discharged? So that she knows throughout the hospital stay too, when that support will be available. The third point they made is that, of course, that support is tailored to the setting and the needs of the population group. So are we working with, teen moms, African-American moms? What can we do to address, the different needs that they may have? And lastly, that support, may be offered either by professional or lay or some type of, peer support, peer counselor, or a combination of both. So what that may look like is mothers who have access, say, to the WIC breastfeeding peer counselors. They may, see a peer counselor prenatally. Then they may have the RN or IBCLC in the hospital who's offering, support. And then they may have access to that peer counselor or some other kind of, community support after they go home. Now, I think I saw that we had Amanda on the phone too. I know in some states they're actually now working, WIC in some states is now working with hospitals to get their trained breastfeeding peer counselors into the hospital setting so they can make that contact with the mothers around time of delivery. And then, then they know the baby's been born, and they may know what's, happening in those critical first couple of days, and then be able to provide even better support after that mom goes home too. So this was all out of the Cochrane review. So that was, once again, kind of that first question, giving the support. Does that, increase exclusive? The answer to that was yes. Then the second part of this question, should mothers giving birth be shown how to practice expression of milk compared to not showing them how to express milk in order to increase rates of exclusive breastfeeding during this day? And so when they reviewed the evidence, they said this should continue to be recommended, but the quality of evidence was a bit lower. And this was really interesting to look at this, and I can see, where they could run into some trouble with this one. So they had a Cochrane review from 2016 that was a review of methods of milk expression. And so this, of course, had smaller numbers than that previous Cochrane review, 41 studies with about 2,300 participants. Now, of course, we had a lot of mixed populations here because we had the majority of the trials were mothers separated from their babies with NICU infants, and 14 trials where maybe the mothers were doing some expression, but they had healthy baby who went home with them, and then one trial that combined both of those populations. So and so some of the conclusions that came out of this Cochrane review were that the most suitable method for milk expression, depends on a lot of factors. How long has it been since, the time since birth? How old is the baby? Why are we needing to express? What's going on with the individual mother and baby? Do we have any health issues on the part of the mother? Is this a baby in the NICU, or is this a baby in the room, but we had hypoglycemia? So those are all very different kinds of situations. And this other conclusion, I think we will all appreciate this, is that they said low-cost interventions, including initiating milk expression sooner after birth when we have a baby that's not feeding, and then using relaxation, massage, warming the breast, hand expression, and lower-cost pumps may be just as effective or even better than our big fancy hospital-grade pumps for some outcomes. So I thought that was really interesting. So definitely they're calling on more research. And lastly, they said we need independently funded research for more trials on these lower cost interventions that don't have a commercial potential. So once again, kind of similar, in one sense, there's a parallel there with the formula industry. When you have, when you can sell more of your product, you want to make a case for you have the best breast pump out there. And then every mother needs a breast pump, right? How many times do you have mothers these days coming in asking when they're going to get their breast pump, whether they, have a medical need for one or not? So that's how much marketing and promotion has happened with the breast pumps. So anyway, I thought that was really, really interesting. So just to add on from a different perspective, because I know y'all all have had mothers who end up, for whatever reason, either by choice or by circumstances, exclusively pumping. So this was a study that was published in Breastfeeding Medicine last year of mothers who were exclusively pumping. The babies never actually fed at the breast. And they found that if we ended up exclusively pumping, we had shorter milk feeding duration, and we were more likely to introduce formula much sooner. And so the conclusion they had was that establishing feeding at the breast may be important for achieving human milk feeding goals. So if the mother's goal is to breastfeed or human milk feed for 6 months, she's less likely to achieve that goal if she's exclusively pumping. And there were some differences in the mothers who ended up exclusively pumping. So they're more likely to have had a preterm baby. So there we have birth-related aspects of being separated and NICU stay and challenges there. And then they also found in this study that mothers of lower socioeconomic status were more likely, which probably reflects some, lower education levels as well. So, all right. And lastly, in step 5 is about the formula feeding instruction in the Baby Friendly USA guidelines. And they didn't address this at all in their review of the evidence. So we can't, say if this is helpful or not, though most logical minds would think that it's important for mothers to know, mothers who are formula feeding, that know how to safely prepare that and safely feed that to their babies. I actually emailed Baby Friendly USA about this to make sure I wasn't missing something, and they said they don't know why it wasn't addressed in there either, other than if you just look at kind of the basic 10 steps, this is not mentioned, though it's been included in the WHO guidelines since 2009. So they don't know for sure why they didn't. All right, so I'm going to pause there for a second before I move on. Any questions from anybody so far? There, and I don't see anything in the chat box. Ruth saying thank you. Vicky said audio garbled earlier. I hope it's okay now. Hope everybody can hear me okay now. Okay. Hate to find out when we listen to our recording. Oh, Vicky says okay, good. Okay, thanks. All right, so let's move on and look at step 6, or what I call the exclusive breastfeeding piece. And once again, copied straight out of the guidelines, step 6 basically says give infants no food or drink other than breast milk unless medically indicated. So obviously, babies who are breastfeeding, we want to send them home exclusively breastfeeding. Babies who are not breastfeeding, we need to feed them. So that's a medical indication. And then there's that group in the middle, which we'll get to. But anyway, their translation is exclusive breast milk feeding shall be the feeding method expected from birth to discharge. So if the baby is supposed to be breastfed, optimally, we would send that baby home 100% human milk fed while they are in our care. So some of the couple of points that Baby Friendly USA, not the actual bullet points, but a couple of other points they had in the intro to step 6. One, and I reached out to them to get clarification on this too. One is strive to reach the Healthy People 2020 goal for exclusive breastfeeding at discharge, which is 85.8%, or around 86% of your babies who are breastfeeding should go home fully breastfeeding or human milk fed. So that, and now we know that, many places are not anywhere close to that, that you should be striving to move towards that target. And Baby Friendly USA does not specifically evaluate hospitals on that number. So I hope that makes sense. But they do want to know, and as we get into the details, I'll explain a little bit more on that. The other is that when you look at what your exclusive breastfeeding rate is, say it's 60% or 50% even of your babies, so then you've got 40 to 50% that are being supplemented. Well, then you should analyze, why is that happening? And how many of those babies were supplemented for really not a medical reason? Maybe, it was maternal request. So what are we doing about that? And that from a year-to-year basis, are we trying to reduce that number? So that's what the overall goal should be with step 6. So then in some of the details, 6.1 really was the only bullet point they had with several under it, was if the mother has no plans to breastfeed, or she requests formula, then we should talk to her about it. Staff should explore the reasons if she's requesting formula, address any concerns raised, and then educate her about any possible consequences, particularly to the breastfeeding success. And once we've had that conversation and provided that education, and the mother still requests, then we, of course, grant that request and document that she made an informed decision. So, and so that's the hard part, I know. Step 6. And any other decisions to give breastfeeding infants something other than breast milk should be for a medical reason, and have a written order documenting when and why that supplement was indicated. So, all right. So let's look at what WHO's review found with this one. And this is where step 6 now moves into their other grouping of feeding practices and additional needs of infants. So several of the steps of the 10 steps fit into this category as opposed to kind of initiating. So feeding practices and additional needs. And they really only had one question for step 6. Should newborn infants be given no foods or fluids other than breast milk unless medically indicated, compared to giving them early additional foods? And does that impact rates of exclusive breastfeeding during the birth stay? So during the stay at your facility. So supplement versus not supplement. And so once again, if Becky Mann was in charge, WHO didn't ask me. But to me, this is an oxymoron. How can you say that you're exclusively breastfeeding when you've given something other than breast milk? So I think we, could do a little bit with the wording, but that's my problem. Anyway, so as they said, the available evidence, this was still definitely a recommended step, and this had their overall review was that this was moderate quality evidence. So here's a Cochrane review that they cited in this. This is from 2016. This was a systematic review of, as they all are, of 11 studies with about 2,500 randomized mother-baby pairs. They had some challenges with some of these, even these randomized trials. You had some bias in the studies, it's particularly selection bias, how were the mother-baby pairs chosen, and it was difficult then to kind of pool the results from all the trials, which is what they, try to do if possible. However, what they overall found, pretty much, all of the trials found that rates of breastfeeding were lower in the supplemented group. And they cited one of the larger trials that really followed that through several different time points. So you found lower breastfeeding rates in the supplemented group at 4 weeks, 8 weeks, 16, and 20 weeks. And so the overall conclusion was that there was no evidence to disagree or change the current recommendation of exclusive breastfeeding for 6 months, which was the point of this particular review. But WHO, of course, was wanting to know also how does that early supplementation affect EBF in that shorter window of time. So I also wanted to bring in, because this came out after the WHO review came out, and I cited this in one of the earlier webinars as well. I think, the one that had steps 1 and 2. So this was from AHRQ, the Agency for Healthcare Research and Quality. It just came out this summer, and that's a copy of the kind of summary of the publication. And they absolutely reviewed some of the evidence, in the baby-friendly facilities or facilities that were working on it. And their overall key message was that they found the baby-friendly hospital initiative was definitely associated with improved rates of both initiation and duration. Okay. And so here, bear with me, this is a busy slide, and I'm going to see if I can be really savvy and use my little highlighter thing. So in this first section up here, where they were looking at certified baby-friendly hospitals versus, hospitals with, no status, not working on it, or implementing any of the steps that, that they could confirm. And so they actually had, they had over 1 million subjects in this study. And they found, if you look right here, exclusive breastfeeding initiation, they found significantly higher rates of exclusive breastfeeding at discharge. Whoops. If they were in a baby-friendly accredited hospital versus the control hospitals. And this had, anywhere from 3 to, over 50% variance. Now, when we went down to some of these others, this second one down here looking at, once again, baby-friendly accredited, and this was actually looking at some evidence from observational studies. They found, because we're focusing on their question of exclusive breastfeeding, if you look down here with exclusive breastfeeding duration, they had higher rates of EBF over 1 to 2 months among infants born in the baby-friendly hospitals versus controls, so anywhere from 4 to 25%. So, yeah, definitely some, changes there. Now, adding in also another interesting systematic review that came out in 2015, timing of breastfeeding initiation and exclusivity of breastfeeding during the first month of life, and how did that affect neonatal mortality and morbidity. So this had studies, they reviewed studies in both developed and developing countries. They said the quality of the evidence was moderate because these were well-conducted observational studies. And they found that initiating breastfeeding after the first hour doubled the risk of neonatal mortality, and partial breastfeeding in the first month of life significantly increased, the risk of infections, sepsis, respiratory, and GI infections. So that's just another one that, WHO didn't specifically include in their review, but I think adds to our information here. And lastly, in this category, and I cited this in our last webinar where we talked about step 4 as well, because I thought this was a really interesting one that just came out this year. Baby-friendly practices minimize weight loss, because we're all worried about, and the mothers or the families, the doctors, everybody's worried about, is that baby getting enough milk? And if the baby's lost too much weight, is that a reason we need to start supplementing? So this was a retrospective case control study, and we had 1,000 term babies. So these were healthy babies in the room, not going to the NICU or late preemies or anything. 1,000 term babies born in this facility before they were baby-friendly designated. And then they matched them with 1,000 babies born after baby-friendly designation, so in the same facility. And they looked at birth weight, of course, their weight during the stay. They looked at the type of birth, C-section versus vaginal delivery, feeding type, and then, of course, patient demographics. And they found that, interestingly enough, whether the baby was breastfed or formula fed, the mean weight loss went down in all across all feeding types. So once again, some of those pieces of baby friendly that are also good for formula feeding babies, the early skin-to-skin contact, the rooming in, educating mothers and so forth. But that they also said there was a significant decrease in the weight loss for the exclusively breastfed babies. At the same time that they had exclusive breastfeeding increasing in all ethnic groups. So this was a study that also shows that baby friendly helps close some of that disparity gap, where we have higher breastfeeding rates in our white families than we do, say, in our African American and Native American families. So that was really interesting. Once again, baby friendly helps kind of equalize the opportunity, if you will. So I think that's an interesting study to kind of have on your radar and maybe share with some of your physicians as well. Okay, so as we've done before in this last section, just kind of talk about, what are some of the barriers to these particular 2 steps. And I'm still citing from this publication that came out in 2004, just because I think some of the barriers that they cited and identified at that time, we still struggle with. And you tell me if you disagree. And there may be, some others that, this is where people can definitely pipe in. And I'm just double checking that I didn't miss anything in the chat box either. Okay, move that out of the way. So anyway, so some of the barriers that they cited were inconsistent advice in teaching amongst the staff, limited staff competence in assessing and educating mothers, and limited staff time. So what do all these barriers have to do with, really? One of the other steps, step 3, which is step 2, which is your staff training. So if we have staff that have had the required baby-friendly training, we're evaluating their competence on a regular basis, then number one, it should actually take them less time if we've put a lot of these steps into place and we're not making breastfeeding harder and creating some of the breastfeeding problems that we used to commonly inadvertently do. But yeah, then we should, remove a lot of these barriers. So has anyone seen any different barriers to step 5? And how do I get rid of this thing? I don't want my pointer on here anymore. Anyone that's had any different barriers in step 5 was show mothers how to, position and latch and teach milk expression, especially if they're separated. So that was step 5. So anyone that's had any, or would you kind of all agree that what they've listed here is maybe some of the main barriers that y'all are seeing? All's quiet out there in cyberspace. All right. Well, some of the strategies they had to help with step 5 to overcome some of these is Vicki says we've increased the amount of training. Yeah, so they've found that they needed to do more training. So you can do your basic training, and then you still need to have some, I think, ongoing training. You can't do it one time and then 3-4 years go by and you haven't continued to update and especially assess staff competencies. So some of the strategies that they mentioned, get a working group to look at your methods of breastfeeding assessment and teaching. Are we all on the same page? Are we pretty consistent? Can we create a team of staff members? This is kind of what I think of as, who are your breastfeeding champions? Do you have lactation consultants? Do you have RNs that, have had, additional training that, can kind of be your breastfeeding champions? Ruth is saying, good to see strategies coming from all angles. Yes, I agree. And then if you have those kind of your expert or your champions or whatever, can you assign your less experienced, less confident staff to shadow them and then eventually swap roles so that, your learners are, moving up in their expertise. And then once again, here we hear about peer counselors. I thought this was really interesting. Train peer counselors to make rounds. So once again, is this, an opportunity? Is it time to start looking at how we might partner with WIC to get some breastfeeding peer counselors into the hospital setting? So I thought that was really interesting. So I've already heard from Vicki that they've just added some additional training. Anything else from anyone else that's they found has worked at their hospital to kind of get step 5, get everybody consistent in how they're teaching and supporting the moms with position and latch? Anybody have anything else to add to that? And you can always type in the chat box if you think of something. So, all right. So let's move on to step 6. So overcoming barriers to step 6. This was the exclusive breastfeeding piece. I think this is a hard one. They cited, just routine supplementation of breastfed infants. Where does that come from? And then misconception about contraindications to breastfeeding. So maybe, a mom was positive for Hep C and, they didn't let her start out breastfeeding, or something. Or maybe it was a medication they thought was contraindicated, but it wasn't. Who knows? We've had, all of those things happen. Or in this last one, I thought was kind of, and this, of course, dates back to 2004, so I would say this one's getting a little outdated, but concerned that parents will choose another facility if they don't get their free discharge gift bag. Now, we have a lot of states around the country now that are completely bag-free, and we have 60% of our Oklahoma hospitals that no longer give out the formula gift bags. So, I don't think that's, I would hope that's not seen as a barrier for most of us today for step 6. But definitely, routine supplementation, and where is that coming from? Is it coming from the maternal request side of things, or is it coming from, physician side of things? And I think what I hear from people, staff in hospitals, that we've worked with is, sometimes a combination of both. So those are definitely challenges. So strategies they cited, have a medical review team to look at your, what are policy statements? What is that list of medical reasons that we might need to supplement a breastfed baby? Are we actually following the most current guidelines? So is that how we can try to work with our physician team, our pediatrician team, or family medicine, our pediatric providers? Educate staff of what are true medical contraindications versus, we need to keep mother and baby in the room, we need frequent feeds, and so forth. Do we need to work with marketing? Of course, this gets to the discharge gift pack issue. And then the last one, how much formula are we actually using or need versus what gets shipped to our hospital? Because if we're still getting all of our formula for free, we're probably getting flooded with formula. And so do we need to, lock that up, have some kind of closer check on that, and, make sure it's getting, is there a way that it can be scanned out to a particular patient? I know one of the frustrations I encountered when I was still working at OU Medical Center was the way formula was packaged and then delivered to our, through the supply chain to the warehouse, is that it came in the 4-pack or 6-pack. And we didn't want to take a whole 4-pack into a mother's room. If we needed, to use a little bit of formula for a couple of feedings or something, we wanted to take 1 bottle. And there wasn't a way to just scan out 1 bottle in the system at the time. Now, I don't know where they are on that now, but that may be a similar challenge in other facilities too. Comments or questions, from anyone on step 6, what has worked, and maybe, what are you seeing as, some of your barriers to step 6? Comments on that? Would you feel it's that the bigger barrier is maybe maternal education, that it's maternal request, the baby's not getting enough, I need to give formula, versus physician routinely? No, do not restart my computer. I love things like that. Or some combination thereof. Yeah, so any comments from anyone out there? All right. No one's having any problems with step 6, which would be fabulous. So that's really, kind of the end of the overall focus of our webinar today. And so the last few slides, just a few reminders on upcoming events or educational opportunities. And once again, you can always go to hopefully the COBA calendar to see, some other events too. But we have a 2-day training, Breastfeeding Basics and Beyond, that we offer quarterly. It's usually either in Oklahoma City or Tulsa. The 1-day, Making Breastfeeding Easier, we continue to schedule quarterly here on campus, but that's also the class that your facility can ask, to have it scheduled at your facility or in your community. And that's no charge. None of these, these are all funded with our health department contracts through their Title V federal funds. And then we also have the 15-hour online training for healthcare staff that helps hospitals meet the Baby Friendly USA requirements. And that's if it's a hospital that's enrolled in our state BBFOK program, it's $30 a person for 15 CEUs, very, very cheap, and $60, for anyone else, which is also still very cheap. So you can email us directly if you have people to enroll. More excitingly to me is our annual summit coming up on February 22nd, and I'm very excited about our speakers this year. We have Joan Meek, who is a pediatrician, and she's currently chair of the American Academy of Pediatrics section on breastfeeding, which is their largest specialty section, and they have 800 pediatricians that belong to that, so that's huge. And then Kathy Carruthers, some of you may be familiar with her, and she's helped develop the National WIC breastfeeding curriculum, and she's done some webinars for us in the past. So she's really fabulous on those communication pieces. So that's our 2 main speakers. And future webinars, of course, we continue to aim for the second Wednesday of the month, barring any other conflicts. In January, we're going to take you on a tour of our hopefully very newly launched, I'm looking at Sarah here, who's done a lot of behind the scenes work. So anybody that's visited the OBRC website and thought it had a little room for improvement, yours truly included, it's getting vastly improved. So January will take you through what's on our website and where to find some of the resources, to help you in your work. February is our summit, so we won't have a webinar that month. And then March, we'll come back to the evidence behind the 10 steps and look at steps 7 and 8. Also, we have the Strong and Healthy Families Expo, which will be here at the Children's Hospital's big atrium on January 18th. And a special piece of that, and something we haven't ever done before, but we're kind of partnering with the OU folks when they were having this big expo already, is we're going to celebrate 10 years of the Oklahoma Breastfeeding Hotline. We're very, very excited about that. And whoops, that is the end of our webinar today. So I will just stop there and see if any other questions or comments from anyone before we close out. So, and you all know how to get hold of me too. So if you think of questions later, you can certainly always email. So, all right. Well, we will, call this a wrap. And since it's December, yes. Merry Christmas, Happy Holidays. Hope everyone has some time off and has a safe holiday season. And we will talk to you next year. Thanks for joining in.